Fala pessoal, tudo bem com vocês? É um prazer estar aqui mais uma vez no OFT-Cast. Vai ser mais um episódio internacional. Então é muito prazeroso estar aqui com figuras muito importantes da oftalmologia brasileira e mundial. Por isso eu agradeço a Zeiss pelo apoio nesse episódio, por ser uma grande parceira aí da OFT Review e do OFT-Cast. Esse episódio vai ser em inglês, então quem preferir ver com legenda, só ir lá no YouTube, vai estar legendado para vocês. Então, não tem nenhum problema quanto a isso. Então, vamos lá, pessoal. Hello, everyone. This is the OFT-Cast. I'm glad to be here another time with an international guest, Dr. Florian Kretz. I thank Zeiss for their support in this episode. We will be discussing the new launch from Zeiss, the new trifocal AT ELANA that is coming right now to Brazil. So, I'm very glad to be here with Dr. Florian Kretz. Welcome, Dr. Kretz. He's CEO at Precise Vision in Reine, Germany, and the lead surgeon in this institute, and the main investigator of the clinical trial with AT ELANA. Welcome, Dr. Kretz.
Thank you very much for having me, Renat.
I would also like to welcome Dr. Arthur van den Berg, a great surgeon, a great friend from Brazil, and responsible for the first implantation of ELANA in Brazil and Latin America. Welcome, Arthur.
It's a pleasure to be here with you guys and also with my Deutsch friend, Florian.
And last but not least, my dear friend, Dr. Mariana Hollander, great specialist in cataract and refractive surgery of the University of São Paulo. Welcome, Mari.
Oi, pessoal. Hi, everyone. I'm very glad to be here once again.
So to begin with, Florian, I want to ask you about the context in which AT ELANA was conceived, and what gap does it fill within Zeiss' portfolio of intraocular lenses?
Oh, AT ELANA actually fills quite a few gaps. If you look at the optical design, for example, you can see it's kind of like a mixture of existing technologies. The base optic is aberration neutral, like the 409. The trifocal profile is very similar to the AT ELITA, but it is different. And with that combination that Zeiss has learned and experienced from their other IOLs on the market, they have built something completely new. So you have a trifocal lens now that has a very flat defocus curve, especially in the intermediate range. The times were in like less than 80 centimeters down to 45 centimeters. Visual acuity decreased quite significantly, and patients felt that they couldn't read on notebook distance or tablet distance that well is gone, because that is really something that is filled with the ELANA. Also, it is on a hydrophobic platform with a C-loop design, so it offers great stability. The base optic gives it the potential to be less impacted by decentration or tilt. So it actually filled quite a big gap of what was available and what wasn't available for Zeiss. And for all those users that prefer, for safety reasons, to use hydrophobic materials, it is available now.
No, very, very interesting. We are going to go deeper in every point that Florian mentioned. I want to ask Arthur about AT LISA, because Zeiss already had a trifocal IOL, the widely known AT LISA. And I want to know the main difference between AT LISA and AT ELANA.
As Florian already mentioned, ELANA is spherical aberration neutral and hydrophobic C-loop platform, and increased light allocation towards near vision. That's another difference. And did I miss something, Florian?
No, not really.
Okay, I think that's the main differences between them.
The platform and the material.
Yes.
Are the most important difference.
Yes, ELANA was designed to meet a market demand for hydrophobic trifocal IOLs, especially in Brazil. So I think the main difference is the platform. Yeah.
Do you mind if I just expand a little on the light distribution? I wanted to ask Florian, just to explain to the audience, how is the light distributed, and compare AT LISA with AT ELANA?
Okay, so if you look at the AT laser has a central trifocality zone in the central 4.34 millimeters. The periphery of the optic is bifocal. With that, if you look at the light distribution over the whole surface of the lens, you have roughly, I think, 52% of light for distance. In the intermediate range, I think it was around like 18%, and then in the near, it is the rest. If you come to the periphery of the IOL, the intermediate, basically, there is no more intermediate. So you only have the central part for intermediate, which was good because under dim light conditions with a large pupil, you really have an excellent near visual acuity. And everyone knows intermediate vision is usually with backlight devices. So you don't need that much.
So you don't need that much light. Yeah.
Exactly. With the ELANA, what they did is they put the trifocal profile over the whole optical surface. If you know the basic principle of trifocality, it means that every diffractive structure creates stray light. So you have first order, second order, third order, and they always double with the dioptric power. That's why usually the intermediate focus of a trifocal IOL is half the dioptric power of the near focus, because the stray light of the next higher order is transferred onto the next focal point. So basically the near uses the stray light from the intermediate.
So you'd have like a little less lost light than a bifocal, for example.
If you have a central trifocal optic and the periphery is bifocal, it means that in the periphery, that light is lost completely. So in the periphery, you have like 17% loss of light. And in the central trifocal part, you only have like 10-12% of loss of light.
Right.
Now, with stretching the trifocal profile over the whole optical surface, you have 12% loss of light over the whole optical surface. So you have a higher light transmission and efficiency. With that, it enabled Zeiss to take 2% from the distance focus and 2% of the intermediate focus to transfer that light onto the near focus, giving the near even more strength. That the base optic is is aberration neutral in combination with an average cornea just means that each focal point you stretch out, like in a monofocal plus IOL or advanced monofocal.
So you would have like a little aberration, spheric aberration.
Exactly. This means with this trifocal IOL, you have a smoother transmission between the focal points.
Right.
Zeiss has tested that in their trifocal EDOF in the AT ELANA. That was also an aberration neutral trifocal with a lower head power, giving a really smooth defocus in the effective range that they were targeting.
Really extended focus, like not steps.
Exactly. Now they transferred that on the trifocal profile. And with that, that's why with the laser tree, you really had those 80 centimeters on the spot and 40 centimeters. Now you have the whole range from 80 to around 60 centimeters. And we tested intermediate visual acuity in 80 and 66 centimeters just to prove that there is no large deviation in that range.
Awesome. So do you mind just, if I ask a little something, that the central area, is it different or is just the difference in light distribution just because of the periphery? Like for a patient that has a smaller pupil, does it make a difference between AT LISA and AT ELANA?
The trifocal profile is different over the whole surface because
so the light distribution is a little different.
Yeah, because you're allocating 2% from distance and 2% from intermediate to near.
To near,
so
even in the central area. Okay.
Over the whole area as well.
Right. Awesome. Thank you.
Oh, it's so nice. And Zeiss already had a C-loop IOL, the monofocal CT Lucia. What features of this platform have been incorporated into AT ELANA, Dr. Kretz?
Well, I think the main features that really bring a great benefit is the general design and the haptic and optic design. So the Lucia platform has a 3-point fixation. That means in the equator of the capsular bag, the haptics are holding the lens in place. But because the haptics in general are elevated in relation to the optic, you have the whole optic that is pressing against the posterior capsule, giving stability. And I think that stability is very unique. Technis uses something similar with the trifix, how they call it, which is the same principle, but you just give the lens more stability. With elevating the haptics, especially in smaller capsular bags, you're also creating more space for the haptics to come closer to the optic if the capsule shrinks.
But without tilt of the
Any tilt of the optic, because the optic is lying flat on the posterior capsule.
Right.
And we know with hydrophilic IOLs or even hydrophobic IOLs that are in one plane, those lenses can tilt if there is anything happening in the equator, and that tilt would not be very beneficial. Even that type of optic tolerates quite a bit of tilt and decentration.
So talking about tilt and decentration, I wanted to ask the next question for Arthur. How does the neutral aspheric aberration can benefit the patients?
This is for less sensitivity to decentration and tilt caused by ocular imperfections. So any kind of decentration in a negative spherical aberration IOL induces higher order aberration, specifically coma, and it may impact the quality of vision.
Perfect, Arthur. Going a little bit deeper about the material, this high quality hydrophobic material of AT ELANA. Could you explain the AB number, what it means, and compare it to other IOLs on the market?
The ELANA's AB number is 51. It's quite high. Higher AB number means lower light dispersion, reduced chromatic aberration, and better visual quality.
It's a great AB number compared to other IOLs on the market.
Yes, comparing to others, the Panoptics from Alcon is 37, the AB number, and Hoya is 43, so it's high compared to others hydrophobic platforms.
Do you think this number is important, Florian?
Oh, it is important, because if you look at use-of images that are projected through those IOL, sometimes, you have this feeling, you see the border, but it's not really sharp. It's like there's a shade beside it. The higher the AB number goes, the less that shade becomes and the sharper the images. And we are working with complex optics, and we are putting complex optics in the probably most imperfect optical system in the world, in the human eye. So the only thing that we can do is we can try to make those complex optics as perfect as possible to compensate for the natural imperfection. And that's why I do believe that makes a difference, and it reduces shadowing, it reduces glare for those patients, and it gives them a better optical quality, because all we have is physics, and what we can't restore is true accommodation. So we need to find ways between physics in the imperfect eye to give the patient the feeling of accommodation and make them spectacle independent.
Yeah, I think something we see in the industry is that it seems like it's a little more difficult to achieve higher AB numbers with hydrophobic materials. Usually we can find higher AB numbers in hydrophilic materials, and Zeiss pulled it off to get a higher AB number with hydrophobic. So the next question I wanted to ask Florian about the lens being preloaded and about the blue cert. Do you have any tips, or can you talk a little about the injector?
Oh, it's a pretty straightforward Medicell injector that Zeiss is using. And it's pretty simple to use. What helps is if the lens is not too cold, especially in the initial folding. So if you have a really cold OR, it does help to keep those lenses on like a warming pillow or something, because then they just fold a little bit smoother. Personally, we just fill a little bit of HPMC, 1%, in the chamber. HPMC is very cheap, but it makes the cartridge very smooth, so the IOL can glide very easily, and it doesn't make it stuck like hyaluronic acid. I implant.
So sorry, do you put the HPMC inside the eye or just inside the
just
cartridge?
Inside the cartridge.
Okay.
I stabilize the eye with an irrigation port, because that also gives me a secondary instrument. So sometimes when you implant those hydrophobic IOLs with a silicone plunger, The silicon plunger is not like the metal plunger in a Monarch or like the stiff plastic plunger in a Hoya inserter that just pushes the lens out, and sometimes you even see the mark on the lens. It's silicon. So if the lens is thicker due to the dioptric power, you can't push it that easily through the cartridge. So you have the feeling the lens doesn't come out completely. But what you can do, because it's a push injector, is you just pull back a bit, and basically the HPMC in the cartridge tip will come back and build a little bit of a pillow behind the trailing haptic so you can push it in. The other thing with the implantation technique that we use with having a secondary instrument in the anterior chamber with the irrigation port, you can just go at the end of the IOL on the cartridge and slowly pull it out and straight away push it with the instrument into the capsular bag without really touching the iris. So it's a very handy procedure. And the other thing is you don't have to extract OVD behind the optic. So it makes it a little bit faster, more efficient, and at least felt with less risk for hypertension the next day.
What about patient satisfaction and the dysphotopsia profile after the first 100 cases that you have? What can you say, Florian?
Or like with any diffractive structure, those patients do see halos. We feel the halos are not as distinct as with the AT laser because we don't correct for the spherical aberration. So they're slightly bit more clear. If we compare our old comes with the laser 3 that we evaluated a lot to now the AT ELANA outcomes, I don't think that there is a significant difference regarding dysphotopsia with the ELANA for those patients. So it's not better, but it's also not worse. So it's on a very similar level. In general, our patient satisfaction rate in the study is quite high. We did have a slight hyperopic outcome in the beginning. So we started to target on the first minus now in the biometry to not go in that hyperopic range. And I do believe that that was the reason why our uncorrected near visual acuity only reached around 0.15 logMAR and not better, and why patients are not super satisfied with that near vision. But I do believe that with optimizing the A constant in the future and finding the right target, that will also become better for the uncorrected near visual acuity. Uncorrected distance, uncorrected intermediate is perfectly fine, and the patients are super happy with their outcomes.
Great. I think we've talked about this many times on the podcast, how important it is to get plano outcome in trifocal IOLs. Even like some residual hyperopic results can impact on the visual acuity. Arthur, could you talk a little about how you are targeting the patients and which constant are you using for calculation?
As Florian mentioned, I started choosing the first negative target because with this target we get very near from plano, and the results are really good in these first cases. So, but it need to be improved. You know, probably in a few months they will change something and improve that.
So improve the optimization of the
optimization. Yes.
Great.
You know what you shouldn't forget is when you talk about AT ELANA, if you look at the effective defocus curve, that defocus curve is with visual acuity better or equal to 0.2 logMAR is reached from +1 to -3. That means you still have one diopter in the plus direction that you can actually work with. So the big question is going to be, how are we going to optimize the A constant? Are we going to shift it quarter a diopter, or are we going to shift it maybe 0.3 diopters to find the optimal outcome for the whole range of vision? Because it's not just distance vision that we want intermediate and near to. And also because the focus goes in the plus area, proper refraction is actually not that easy. Because we all tend to sometimes over-refract of patients because they accept the the plus glasses that we give them, but the visual acuity actually does not increase. They just can still see the same even with that plus refraction. those complications we do know from any other complicated optics, especially from monofocal plus and neither IOLs, where it's really not that easy to find the right refractive outcome. And that's why here we probably will need a larger number of cases to really get a good optimization and then find a joint consent to say, okay, that's the spot we want to land with that IOL, and that's the way we have to put to optimize the constant.
Yeah,
Did you
I
use
think
Barrett to all cases?
Yeah.
I think that's a very important point, because I think one of the I don't know, something to look in papers is that sometimes they compare the results with like distance corrected vision, and we don't know how they corrected for distance vision, especially with monofocal enhanced IOLs. So it's hard to know how the depth of vision really worked. So would you recommend for now targeting different for patients, like for example, patients that are previously myopic and they want like very, very good near vision, like targeting maybe a little more myopic, or would you choose like the first negative for everyone?
Well, at the moment we are choosing the first negative for everyone, because you need some degree of standardization to basically find a baseline that you can work from. In the practical use, also with other trifocals, we did do that we targeted one eye for high myopic patients, slightly myopic up to half a diopter into myopia after counseling the patients. Because if somebody was like -6, -7, and they are really used to like reading in 20 centimeters, then they are very happy with the slight micro monovision, even with a trifocal IOL. But it's not very often that we have to do that, or that we actually consider doing.
Florian, to conclude, I think it's important to our audience to listen from you about your study. Could you briefly say something about the design of the study and the results for us?
It's a multi-center study between the University of Heidelberg, our center, and another center in Spain. We recruited healthy eyes for cataract surgery and for refractive lens exchange. We are aware that that it's two different populations, and that the different populations also might affect especially the subjective questionnaire outcomes at the end, because refractive patients have a different view onto the symptoms compared to a cataract patient that already had symptoms from the cataract before. We included patients that had less corneal astigmatism than one diopter. We did try to reduce the astigmatism by placing incisions on the steep axis up to half a diopter. We placed one incision. If we had more than half a diopter on corneal plane, we even did an opposite clear cornea incision on the steep axis to reduce it as much as possible. All those patients were operated with a minimum of 1 week between both eyes, up to 3 weeks. That was just like from the protocol. And so far we reached an increased visual acuity comparing corrected distance visual acuity preoperatively to now the uncorrected distance visual acuity postoperatively. We have 95% of patients in ±1 diopter, and I think 93% in -0.75. I think that is also the outliers that we had from the beginning when we targeted straight onto planar or not the first and minus. Distance visual acuity is around 20/20. Intermediate visual acuity is in the range between 0.1 and 0.0 logMAR, and near we are roughly around 0.15 logMAR. But that's for the uncorrected, and that probably has to do with the slight hyperopic outcome. If we look at the distance corrected intermediate and near visual acuity, also in 80 and 60 centimeters, we are in a range of 0.1 logMAR, what is usual and what is requested by the isonome with 0.2. So far, all patients are somewhat happy with their outcome. We have no patients that would choose not to take that IOL anymore. And we can see that the neuroadaptation is really taking place from month 3 to month 6. You really have an increase of patient satisfaction with that type of IOL. None of the IOLs is decentered, so we had no problems with that. None of the IOLs seem to be tilted after 6 months, but we are going to evaluate all those patients after 1 year to also see about PCO and if there is any type of movement of the IOL in the eye.
Perfect. Any final comment?
I think it's important to mention that Zeiss will keep at ELISA in the market. So ELANA is another option. Now they have the hydrophilic platform and the hydrophobic. So I think that's important to say.
It's increasing the portfolio. Right?
Yes.
Florian, do you have any position where you prefer to place the haptics on the C-loop AT ELANA?
At the moment, the AT ELANA is not available as a toric IOL. So personally, what I do, I operate all my patients in local anesthesia. Mm-hmm. So at the end of the surgery, when the IOL is in, I let them fixate on my round microscope light. So I have their Purkinje image. And then I rotate the IOL till I feel that the Purkinje image is right in the center, and that's where I leave it. So it's not that I have a favorite position. Usually it's like an oblique position of the IOL that brings it the most nasally to have the Purkinje image in the center.
Perfect. Thanks, Florian, Mari, Arthur, for the brilliant discussion. Thanks, Zeiss, for the support in another episode. This is the OFT-Cast. See you next week.